students. In this lecture, we'll be covering hypertensive and diabetic retinopathy. The learning objectives of this lecture are that at the end of the lecture, you should be able to tell the etiology, the pathology, clinical features, and management of hypertensive and diabetic retinopathy. So, hypertensive retinopathy is characterized by a spectrum of retinal vascular signs which are secondary to systemic arterial hypertension, wherein the blood pressure is usually over 140 by 90 millimeters of mercury. There are two aspects related to hypertensive retinopathy. They include the severity and the duration. We also need to be aware of hypertensive crisis, wherein the systolic blood pressure is over 180 millimeters of mercury or the diastolic blood pressure is over 120 millimeters of mercury. And this condition has a potential risk for causing end organ damage. So this can further be subclassified into hypertensive urgency, where there is no acute end organ damage. So BP can be controlled over several days or over a few weeks. Hypertensive emergency, on the other hand, can result in acute end organ damage, and so we have to be aggressive in lowering the blood pressure. Malignant hypertension or accelerated hypertension, on the other hand, requires emergent attention, and in this condition, the systolic blood pressure is over 200 millimeters of mercury or the diastolic blood pressure is over 130 millimeters of mercury. So, the pathogenesis of hypertensive retinopathy has three phases: the vasoconstrictive phase, the exudative phase, and then the sclerotic phase. What happens in the vasoconstrictive phase is that there is an increased vascular tone because of the autoregulatory mechanisms, and this results in generalized narrowing of the blood vessels. Now, this phase eventually is quite suggestive of the severity of the hypertension. Then, if the disease continues to progress, that is, if it is uncontrolled by antihypertensive medication, it results into an exudative phase in which there is a disruption of blood-retinal barrier. So, the patient can have hemorrhages, hard exudates, or cotton wool spots. Subsequently, it goes on to sclerotic phase, in which there are arteriosclerotic changes. There is arteriolar narrowing, arteriovenous neaking. Now, this is suggestive of the duration of hypertension, and eventually the patient will develop opacity of the arteriolar wall. So, four scenarios can happen in which hypertensive retinopathy can progress. So, you have hypertensive retinopathy in simple hypertension without sclerosis. This is commonly seen in young individuals, and if antihypertensive medications are given, it is unlikely that it will go on to have sclerotic changes. Then there can be hypertensive retinopathy in senile sclerosis. So this is in elderlies where there is a constant smoldering process that is going on, and that is damaging the blood vessels. We can also have hypertensive retinopathy in hypertension with compensatory arteriolar sclerosis. So this also is seen in young individuals, and usually those who have a renal involvement. And then we have malignant hypertension or accelerated hypertension, which requires urgent attention. The hallmark of this condition is disc edema. So running through the course again, systemic hypertension leads to vasoconstriction, which in turn results in arteriosclerosis, which now involves the arterioles by causing narrowing, and this narrowed arteriole is going to have compromised blood supply to the retina. So there would therefore be retinal ischemia, which would result in hypoxia, and that would release increased capillary permeability. There would be an increased vascular permeability factor, and all this will lead to findings such as retinal edema, retinal hemorrhages, hard exudates, or cotton wool spots. Actually, the word hypertensive retinopathy is a misnomer. We know that the retinal, choroidal, and the optic nerve head blood vessels have different anatomical and physiological properties, and they respond differently to hypertension. So, it would be rather better to say hypertensive retinopathy, hypertensive choroidopathy, and hypertensive optic neuropathy. The clinical signs that we will see in a patient with hypertensive retinopathy include generalized arteriolar narrowing, focal arteriolar narrowing, arteriovenous nicking, opacification of the arterial wall, cotton wool spots, retinal hemorrhages, microaneurysms in a few cases, hard exudates, and retinal and macular edema. In cases with malignant hypertension, we can also have disc edema. Coming to hypertensive choroidopathy, wherein we can see choroidal vascular bed abnormalities, there would be acute focal retinal pigment epithelium lesions, and retinal pigment epithelium will also have certain degenerative changes if the disease process continues. When it comes to hypertensive optic neuropathy, there can be subtle early changes, but there can be late changes in the form of chronic disc edema. Let's have a look at some normal and then abnormal images. So here we have a normal fundus image wherein the AV ratio or the arteriovenous ratio is 2:3 and there is normal arteriovenous crossing. So these are called as the AV crossover points. So whenever we are looking at a patient with hypertension, we need to have a good dilated pupil so that we can look at the second order or third order blood vessels also and see these AV changes in them. Here we have the vasoconstriction phase. There can be focal or generalized arteriolar narrowing. In this image, where we have this blue circle, we can see that the arterioles are narrowed down in this segment. On the other hand, in the image on your extreme right hand side, you see that there is a generalized attenuation of the arterioles. There can be slight segmentation of the blood flow through the blood vessels that are there because of the arteriosclerotic changes that are happening. So the segments that have sclerosis will appear a little tighter and the ones that are not will have a broader segment of blood flow. Therefore, it would be a broken segment of blood flow as you can see in this blood vessel. Over a period of time, if the changes are progressive, there will be opacification of the vessel wall associated with arteriovenous nicking. So at this juncture where we have these white arrows, there is arteriovenous nicking and you can see a white opacified blood vessel. In this image, we have arteriovenous crossover changes wherein the vein tapers under the artery. Just pay focus at this point. So whenever we are looking at a hypertensive retinopathy patient, each point wherever a crossover is happening, that should be our area of interest. And it's always a good idea to draw a retinal diagram when we are documenting the retinal vascular changes. Because today we are seeing AV crossover changes at this point and tomorrow there can be exudation or there can be hemorrhages surrounding this area. So drawing a retinal diagram always gives you a clue to future changes. Briefly, let's have a look at which layers of retina are actually getting involved. So commonly in hypertensive retinopathy, we see flame-shaped hemorrhages. Now these hemorrhages are flame-shaped by virtue of the fact that they are lying in a superficial layer. They are also called as feather-shaped hemorrhages. These hemorrhages have indistinct borders. Blood accumulates at the level of the nerve fiber layer, reflecting the structure of the nerve fiber layer that runs parallel to the retinal surface. They last for about 6 to 8 weeks. On the other hand, dot plot hemorrhages are deeper hemorrhages and therefore they take a long time to clear up. Whatever is relatively superficial will have a brighter color, and dot plot hemorrhages, by virtue of the fact that they are a little deeper, will have scarlet red or more purplish hue to them. Their configuration is also due to the intraretinal compression. So in the layer of inner nuclear or outer plexiform layer, we have dot or blot hemorrhages, and in the nerve fiber layer, we have these feather-shaped, flame-shaped hemorrhages. So, arteriosclerotic changes, we can have Marcus gun sign, which means that there is a compression of the underlying vein at the arteriovenous crossover point. Salu sign, as we can see in the lower image, if you focus at these areas where crossover is happening, suggests that the venules are now getting deflected at these AV crossover points. Bonnet sign suggests banking of the vein distal to the crossing site. So here, the vein, if you see closely, is deflecting quite away from the crossover point. If the changes are continuous, we will see copper wiring, and even in advanced cases, we will see silver wiring. So here you see these silver-like thread-like blood vessels which are so narrowed and totally having arteriosclerotic changes. These are called as silver wiring. Again, another blood vessel with marked opacification. Actually, the entire blood vessel is involved, but the opacification is much more pronounced after the crossover. So, whenever there is increased vascular permeability, there will be exudation. So, cotton wool spots, which are also called as soft exudates, result from that. In patients with exudation, we also have flame-shaped hemorrhages, and we can also have hard exudates. This image shows these fuzzy cotton wool spots which are white with feathery margins. Another patient with disc edema, if you see, there is blurring of margin of the disc superiorly, and at the area of the fovea, there are hard exudates which are arranged in a macular star-like pattern or circinate pattern. Coming over to hypertensive choroidopathy, we know that the choroidal bed, it lacks the autoregulatory mechanism for blood flow. Unlike the retinal bed, there is no blood ocular barrier at this point, and it has a sympathetic nerve supply. Retina, on the other hand, has a very efficient autoregulatory mechanism. It has a blood retinal barrier and no sympathetic nerve supply. So, if the changes are progressive and severe, then in a patient with hypertension, there can be a finding called as Elchnick spots, which are hyperpigmentary clumped up deposits seen under the retinal vasculature. So, deeper in the choroid, you can have these changes. Seagut streaks are also seen in hypertensive choroidopathy. In this, there are dark pigmentary clumps arranged linearly along blood vessels. It is usually seen in patients with malignant hypertension and suggests fibrinoid necrosis. Acute hypertensive retinopathy can result in exudative retinal detachment because there is an infarction and damage of the retinal pigment epithelial cells along with increased choriocapillaries pressure, and this results in transudation of fluid in the subretinal space, leading to macular edema and serous RD, which is also called as exudative RD. So herein we have this image wherein there is detached retina because of collection of serous fluid underneath it. If there is a more generalized shallow involvement, we can see opacified retina, which is not elevated too much, but there is a generalized serous collection underneath the retina. These conditions do not require any surgical intervention. They require control of the causative agent. So we need to control the blood pressure and wait for some time for this fluid to absorb. Hypertensive retinopathy has recently been classified by Wong and Mickle. According to this classification, we call it none if there are no detectable signs. The patient is a hypertensive, but he does not have a hypertensive retinopathy if there are no detectable signs on the fundus. It's called mild hypertensive retinopathy if one or more of the following are present: generalized arterial narrowing, focal arteriolar narrowing, arteriovenous nicking, or copper wiring of the arteriolar wall. It's called moderate hypertensive retinopathy if one of the following is there: retinal hemorrhages, either dot, blot or flame shaped, microaneurysms, cotton wool spots, hard exudates, or a combination of these signs. In cases with severe hypertensive retinopathy, we will have moderate retinopathy along with disc edema. So the management is to control the blood pressure. We need to reduce the mean arterial pressure by 10 to 15% in the first hour. We don't have to be very aggressive in reducing the blood pressure, otherwise end organ damage will ensue. So the blood pressure should be controlled in a very phased manner, no more than 25% compared to baseline by the end of the first day of treatment to prevent any further ischemic damage. Initially, parenteral antihypertensive agents can be given, which can be transitioned to oral drugs. Coming to the next entity, that is the diabetic retinopathy. We know diabetes has taken the world by storm, and India is soon going to be the diabetic capital of the world. So, of course, diabetic retinopathy is also going to increase exponentially. Diabetes mellitus is a chronic disease which is characterized by persistent hyperglycemia. The target organs of this are retina, nerves, and kidneys. If all three are involved, we call it as microangiopathy triad. It induces both micro as well as macrovascular complications. So what actually happens is that if there is a state of hyperglycemia in the body, it will lead to retinal vascular injury and dysfunction. There will be two things, one, vascular leakage, and the second would be capillary non-perfusion. Vascular leakage would result in macular edema, and capillary non-perfusion would lead to an upregulation of vascular endothelial growth factor and vascular permeability factor. And eventually, if hypoxic state ensues and if these VEGF and VPF are elevated in the retina, then neovascularization will happen. We can have neovascularization of the disc or elsewhere, and if this is there, then it runs the risk of certain complications like vitreous hemorrhage or preretinal hemorrhage, and the patient can go on to develop proliferative diabetic retinopathy. We'll be talking about the proliferative and non-proliferative terminology in the subsequent slides. So what biochemical alterations do we expect in a patient with uncontrolled blood sugars? There would be a non-enzymatic glycosylation and advanced glycation end products, also called as AGE, would be there. This would result in upregulation of VEGF production and endothelial apoptosis. So to address this, AGE inhibitors have to be given, but a lot of them are still in experimental stages. Additionally, there would be an increased polyol pathway flux, which would result in basement membrane thickening, and for this, drugs like aldose reductase inhibitors would work. Protein kinase C activation would also happen, and it would induce action of VEGF. So for this, PKC inhibitors would be needed, and oxidative stress that would be there, that would result in elevation in the oxygen free radicals in the retina, and for this antioxidants would help. There would also be associated hematological alterations in the form of abnormalities in the platelets, which would result in increased fragility and adhesiveness, increased endoperoxidases and decreased thromboxane, and decreased prostacyclin. So for this, we need to give anti-aggregating agents. There would be associated RBC abnormalities. There would be a decreased ability of the red blood cells to release oxygen. There would be a decreased deformability of these cells and an increased formation of large exudates, increased whole blood viscosity, and increased adhesiveness to the endothelial cells. Again, we need to give anti-aggregating agents in this scenario. In addition to RBCs, leukocytes would also have certain abnormalities. There would be increased leukocyte adhesions, which would again cause endothelial injury. VEGF release would be there, and there would be opening up of tight junctions, and which eventually would result in increased exudation. So coming over to the classification of diabetic retinopathy, as per the ETDRS, which stands for Early Treatment of Diabetic Retinopathy Study, there are two broad classifications of diabetic retinopathy, non-proliferative as well as proliferative. The non-proliferative can be further subdivided into mild non-proliferative diabetic retinopathy, as you can see in this image, which will have only a few microaneurysms. Now, microaneurysms can appear like red pinheads. So, here in this image, there are small red pinheads in this area and a slightly bigger one in this area. Moderate NPDR, on the other hand, refers to hemorrhages or microaneurysms more than the standard 2A image in all the quadrants. There would be cotton wool spots, venous beading or irmas less than 4:2:1. Now, there is a rule of 4:2:1 for severe diabetic retinopathy, which we will see in the subsequent slide. But here, the cotton wool spots would be less than 4 quadrants, the venous bleeding would be less than 2 quadrants, and irmas would be less than 1 quadrant. In severe NPDR, the rule of 4:2:1 applies. And you can have an MCQ question wherein you are asked that 4:2:1 applies to which classification of or which stage of diabetic retinopathy. So the answer would be severe NPDR. You can get a separate short note on non-proliferative diabetic retinopathy and a separate one on proliferative diabetic retinopathy. So in severe NPDR, we will have hemorrhages or microaneurysms more than that would be seen in standard 2A image. Now, ETDRS study had a standard set of images in which they had captured these findings. So, this finding should be similar to what was seen in the standard 2A photograph of the ETDRS study in all the 4 quadrants. Definite venous beading should be seen in more than 2 quadrants, and irmas can be seen in more than standard photograph A8A of the ETDRS in 1 quadrant. Very severe NPDR suggests there are more than 2 features of severe NPDR in the patient. Then we have another entity which is quite common in diabetics, and it is called as macular edema. This is one of the most frequent causes of moderate visual loss in patients with diabetic retinopathy. It is seen in 3% of cases with mild NPDR and as many as 38% of cases in moderate to severe NPDR. In this, the intercellular fluid, it comes from leaking microaneurysms or there is diffuse capillary incompetence. Hard exudates, as you can see, these gritty yellow prominent exudates, when you see it under a stereoscopic examination, you will see that they are slightly elevated from the surface of the retina. They are very well defined, unlike their counterpart of soft exudates. They are associated with increased serum lipid levels, and usually they border the junction of normal and edematous retina. So, whenever there are hard exudates, you can make out roughly that there is an area of capillary non-perfusion on one side, and on the other side the perfusion is maintained. So, ETDRS also defined clinically significant macular edema, that is edema that requires attention. It is also called as CSME. In this, either of the 3 criteria have to be met. The first is there should be thickening of retina at or within 500 microns of the center of the macula. So, this is the center of the macula. Here, there should be thickening within 500 microns. Now, when you see it under a slit lamp, because of stereoscopic examination, you will be able to make out the thickening. If slit lamp is not able to give you a clear-cut idea, then an imaging modality like OCT of the macula can clear the doubts. The second criteria is that there would be hard exudates at or within 500 microns of the center of macula if associated with thickening of adjacent retina. So, here we have macula, and if this is 500 microns, we have these hard exudates which are well within this 500 micron area. The third criteria is that a zone or zones of retinal thickening 1 disc diameter or larger, or any part of which is within this 1 disc diameter of the center of macula. So we have this area of retinal thickening as well as hard exudates as seen in this image, which falls in one disc diameter of the center of the macula. So either of these three are fit for being labeled as CSME or clinically significant macular edema. There's another classification, which is the International Clinical Diabetic Macular Edema Severity Scale. So that just tells you whether it is absent or present. If there is no retinal thickening or hard exudates in the posterior pole, that means diabetic macular edema is absent. On the other hand, if these are present at the posterior pole in whatever amount, it is called as diabetic macular edema present. So the image at the bottom, the diabetic macular edema is present. You can call it mild diabetic macular edema if there is some retinal thickening or hard exudates in the posterior fold, but they are distant from the center of the macula. Moderate diabetic macular edema has retinal thickening or hard exudates which are approaching the center of macula but still not involving the center. So these hard exudates are somewhere near the vicinity of the center of macula and are eventually approaching the center. Severe diabetic macular edema, on the other hand, in this there is retinal thickening or hard exudates involving the center of the macula. This is quite a bit of exudation that has happened in this area. Then we have another entity, which is the proliferative diabetic retinopathy, in which there is abnormal vascularization, which is called as neovascularization. These new blood vessels usually arise from retinal veins and often begin as a collection of fine naked blood vessels, either on the disc when it is called as neovascularization of the disc or NVD, or they can happen elsewhere in the retina wherein they are called as NVE or neovascularization elsewhere. These neovessels, they tend to bleed. On fundus fluorescein angiography, they tend to leak. So here we have leaky blood vessels, and because of these neovessels, there is a fresh bleed happening in this image. These neovessels also cause vitreous to liquefy, and this liquefied vitreous along with fibrovascular changes in the retina causes a tug on the retina and eventually can result in tractional retinal detachment. There is another entity, that is proliferative diabetic retinopathy with high risk characteristics. So if there is neovascularization of the disc more than 1/3 to 1/4 disc diameter, or there is neovascularization of the disc which is less than 1/3 to 1/4 of disc diameter but is associated with vitreous hemorrhage, or if there is neovascularization elsewhere but with vitreous hemorrhage or pre-retinal hemorrhage, then all these come under the high risk characteristics and warrant urgent attention. The conventional treatment for clinically significant macular edema and proliferative diabetic retinopathy is pan-retinal photocoagulation or PRP. In this, a laser hits the areas wherein there is abnormal microaneurysm or abnormal vascularization. Now, we always start the pan-retinal photocoagulation inferiorly. If you start this process in the superior arcades, then if there is any hemorrhage or bleed, the hemorrhage will gravitate inferiorly and will preclude you from doing the laser of the inferior part. Therefore, inferior retina is always lasered before the superior retina. So, using a argon or a double frequency neodymium YAG laser, these areas are addressed. Laser photocoagulation has the advantage of reducing the legal blindness by over 90% in patients with proliferative diabetic retinopathy. Lasers and other modalities for treating diabetic retinopathy will be discussed in detail in a subsequent lecture. Now, these gray spots are laser spots, and once they progress and they fuse with each other, they can also have clumping of the RPE. So there can be, over a period of time, loss of peripheral visual field, and because of that there can be night blindness and the patient can perceive visible scotomas in their visual field. So laser burns should always be put one laser burn width apart. The recommended eye examination schedule for patients with type 1 diabetes is yearly. For type 2 diabetes also is yearly. For patients with mild NPDR, we need to observe them 6 to 12 monthly. Moderate NPDR requires a 6 monthly follow-up if all is well. Severe NPDR requires a closer follow-up at about each follow-up at about 4 months, and very severe NPDR 2 to 3 monthly. Certain investigations that are required and that would help you to plan your therapy are blood glucose levels, both fasting and postprandial, blood pressure profile, fasting lipidogram, hemoglobin as well as glycosylated hemoglobin, 24-hour urinary proteins, a fundus photograph, a fundus fluorescein angiography, and an OCT of the macula. The blood pressure should be well within the limits, less than 120/80 on or off medications. The 24-hour urinary proteins should be less than 300 milligrams. The lipid profile should have triglycerides less than 150 milligrams per deciliter. Cholesterol should be less than 200 milligrams per deciliter, and LDL should be within 60 to 130 milligrams per deciliter. So basically, the treatment is reducing the blood sugars, reducing the deranged lipids. You can do it either by giving insulin, oral hypoglycemics, or drugs like fenofibrate. Anti-VEGF drugs, that is the anti-vascular endothelial growth factor drugs, which are given as intravitreal injections, help if there is any neovascularization on the disc or on the iris or elsewhere. The drugs include bevacizumab, ranibizumab, and aflibercept. If the anti-VEGF drugs are contraindicated in a patient who has other coronary artery disease or other cardiovascular diseases, then steroid implants such as triamcinolone implant can also be put. Certain patients, especially the ones with proliferative diabetic retinopathy, benefit with pan-retinal photocoagulation, and if nothing works, if it is refractory or if there is tractional retinal detachment, then pars plana vitrectomy is done. All these treatment modalities have been discussed in a subsequent lecture. So for a proliferative diabetic retinopathy, the primary treatment is PRP, and if it doesn't work or if there is an element of retinal detachment, then pars plana vitrectomy is needed. If the patient has macular edema, the primary treatment is intraocular injections of anti-VEGF, and if it is resolved to a certain extent but you still have certain leaky areas, then focal or grid laser can be done. Now, some patients can have both hypertension as well as diabetes mellitus. So, you should be able to differentiate as to which is the dominant pathology and which form of retinopathy is the dominant retinopathy in the fundus. So, for that you need to know what are the salient differences between hypertensive and diabetic retinopathy. The predominantly involved blood vessel in the hypertensive retinopathy are arterioles, while they are veins and capillaries in diabetic retinopathy. AV crossover changes are present in hypertensive retinopathy and they are absent in the diabetic form. Flame-shaped hemorrhages are abundant in hypertensive retinopathy but are rare in diabetic retinopathy. We have abundant deep hemorrhages, hard exudates in diabetic retinopathy, unlike hypertensive form. Cotton wool spots are also abundant in hypertensive retinopathy. Retinal edema is extensive and it is associated with retinal thickening in diabetic retinopathy. So here are two images to show you distinct clinical differences between diabetic as well as hypertensive retinopathy. This is an image of a patient with mixed retinopathy. That means the individual has both diabetes as well as hypertension and has clinical features of both the entities. So we have blot hemorrhages and some superficial hemorrhages and hard exudates and even cotton wool spots. So features of both the disorders are present. So with this, we come to the conclusion of the lecture, and I'll be asking you a couple of MCQs. So the first question is, the commonest lesion which hinders vision in diabetic retinopathy is macular edema, microaneurysms, retinal hemorrhages, or retinal detachment. Now usually microaneurysms are very benign, they are pinhead shaped and they don't cause any symptom, especially in the milder forms wherein we are leaving a patient who has mild non-proliferative diabetic retinopathy with just an instruction to control their glycemic status and come back to us in a year. Retinal hemorrhages usually are more common in mid-periphery. Retinal detachment, which can occur because of proliferative vitreoretinopathy or because of tractional bands, also involves the periphery or the mid-periphery more commonly. Since the light is supposed to focus on the macula, and if macula is edematous, the patient is definitely going to have a compromised visual acuity. So by exclusion, the answer is macular edema. The next question is that we have a patient of old standing diabetes mellitus who noticed sudden muscae violentis or sudden floaters in their visual field. On examination, the red reflex was dim with no details of fundus visible to us. What is the likely diagnosis? Does he have non-proliferative diabetic retinopathy? Does he have cystoid macular edema or vitreous hemorrhage? Or does he have central retinal vein occlusion? Now, whenever there is vitreous hemorrhage, there is a release of retinal blood cells, there is a release of RBCs which are now freely floating in the vitreous cavity, which appear as floaters. So the answer to this question is vitreous hemorrhage. And the last question is, pan-retinal photocoagulation is indicated for which condition? Macular edema, retinal breaks, proliferative diabetic retinopathy, or tractional retinal detachment? And the answer, as we discussed, is proliferative diabetic retinopathy. For macular edema, we give anti-VEGF injections, and if they don't work, focal laser can be done. Retinal breaks require a laser around the retinal break, or eventually you may need pars plana vitrectomy, and tractional retinal detachment also requires pars plana vitrectomy. With this, we come to the conclusion of this lecture. Thank you so much for your patient listening.